Well, good morning, good evening, good afternoon. We're glad that you've joined us today for this ISTH webinar on gene therapy and hemophilia. Our focus today is on preparing for practice readiness in gene therapy for hemophilia. I'm Dr. Stephen Pipe. I'm a professor of pediatrics and pathology, University of Michigan. I also direct the Special Coagulation Laboratory here, and I'm the Pediatric Medical Director for our Hemophilia and Coagulation Disorders Program. And I'm pleased to have joined me today Dr. Wolfgang Miesbach, who's head of the Department of Coagulation Disorders and the Comprehensive Care Hemophilia Center at Goethe University Hospital in Frankfurt. Welcome, Wolfgang.
Yes, good morning, good afternoon, Steve. Hello, everybody.
Yeah, so these are our learning objectives today. As I mentioned, we're going to be focusing on how we are going to be preparing patients for receiving gene therapy, how we'll be preparing our hemophilia treatment centers, and then what the short and long-term monitoring requirements are going to be. So this won't really be a presentation about the clinical trial results, although we will put some context to observations we've made in the clinical trials, which I think are going to be relevant for this preparedness. This is accredited for CME, and you'll learn about how to get your credit at the end of the presentation today. This is the disclosures as it relates to this being a CME presentation. We do have personal disclosures related to a number of consulting activities. However, we're not going to be talking about any specific products today. And we are talking about investigational gene therapy, and of course, none of these are yet approved. We're pleased that this activity is supported by educational grants from BioMarin, Freeline Therapeutics, Pfizer, Spark Therapeutics, and Unicure. So a few questions to get us started. So a poll's going to come up, and we just want to find out what category of healthcare professional you are. So just go ahead and indicate your choice. And then let's move on to the next one here. And we want to know about your area of primary clinical focus. You will have the opportunity to submit some questions during the session. You can use the question and answer section to do that, and we'll try to address those at the end of our webinar today. So this is our agenda. We're going to just give a brief overview of what we know about the benefits and limitations of gene therapy as it's currently being applied in hemophilia. Dr. Miesbach will go through preparing patients for gene therapy and what post-treatment monitoring is going to look like. I'll do a review on the safety and efficacy outcome measures that are going to be addressed even beyond the clinical trials. And then we will each give our own perspectives of what we're seeing about systems for delivering gene therapy. And we're going to give you both a US and an EU perspective on that. And then we'll wrap up about talking about what the long-term monitoring is going to look like across the world. And then we'll finish up with a question and answer time at the end. So there will be a few pre-test and then post-test questions related to this webinar. So here's our first one. Which of the following statements about gene therapy is incorrect? So just identify the single choice that you think is the best answer for this. So we'll just give you a few more seconds to make your answer. Okay, let's move on to the next question. Oh, we're going to ask Dr. Miesbach to give the first overview of benefits and limitations for gene therapy for hemophilia.
Thank you very much, Steve. First, I think it would be important to note that gene therapy of hemophilia is still an experimental approach. But now there are some studies in the phase 3, both for hemophilia A and hemophilia B, and from these data we know more about possible benefits and possible limitations of gene therapy in hemophilia. First of all, this AAV-based gene transfer is a single intravenous injection. And with this, the recent data demonstrate in most cases a clinically relevant expression of factor 8 and factor 9, even up to within the normal range. The durability of this response is demonstrated for at least now in 4 till 5 years in hemophilia A, and probably more and longer than 8 years in hemophilia B. This led to a reduction of bleeding episodes, the possibility to stop prophylaxis, and a significant improvement of health-related quality of life. But still, some limitations remain. First of all, in a few number of patients, there would be a mild infusion-related effect immediately after administration of gene therapy, which is in most cases very easy to manage. There would be a high variability in achieved factor levels, and factor 8 levels particularly may decrease over time. We know that there is an immune response to capsid, which may lead to most cases short-term liver function abnormalities and the need for corticosteroids. Some patients are excluded from gene therapy, for example, with pre-existing anti-AAV antibodies and children. And of course, gene therapy is still associated with high costs and limited availability worldwide. We still not know how long there would be the durability of treatment and would there be any long-term side effects. So this only can be answered with long-term data, long-term follow-up, and long-term registries. And with the existing AAV capsids, redosing would not be possible. Okay, I think it takes some time. Yes, this is also very specific to gene therapy of hemophilia. The inclusion and exclusion criteria are quite similar to any other gene therapy trials, but some are more specific. So up to now, only adult male patients with severe hemophilia have been included who had been on regular prophylactic treatment with factor 8 to factor 9 concentrates. An inhibitor to factor 8 or factor 9 had to be excluded. Some other issues have to be excluded before gene therapy of hemophilia. First of all, pre-existing antibodies to AAV, a significant liver dysfunction and liver damage, and this is a variable defined in different trials, and also some imaging has to be carried out to exclude liver cirrhosis or liver fibrosis. Some other exclusion criteria are hepatitis B antigen, hepatitis C RNA, and it depends from trial to trial. So in some trials, HIV is an exclusion criteria, but in other trials, also participants with controlled HIV can be included. And this is the next question. Which of the following post-infusion adverse events is least likely in patients who receive gene therapy? Infusion reaction, elevated liver enzymes, development of inhibitors to coagulation factors, or thrombosis. Please take your choice. So if we start the discussion to inform the patient about gene therapy and also prepare patients for gene therapy, we can divide the discussion in 3 different topics to enable the patient for informed consent and also for shared decision making. First of all, we are going to explain how the AAV-based gene therapy works. And then we are going to discuss known and also theoretical risks about immune response to AAV, which can be based humoral or cellular, the short and the long-term AAV safety risk, and also transgene protein-related risks. Finally, and this is most important to the patient who want to know, so would it work, how will it work, the available preliminary efficacy data, so regarding the range and the predictability of expression, the durability of expression, and also some facts about the known laboratory measurements we are going to carry out in our laboratory. And about each of these issues, I would like to add some more information in the following slides. Okay. No, I think we have to go back one slide. Yes, especially for gene therapy, it's very important to enable the communication between the physician and the patient to achieve a patient support and a shared decision making, because gene therapy of hemophilia is a one-time treatment, it's not reversible, and it can also not be repeated. And therefore, this shared decision making is a powerful tool for building an open, trusting, supportive patient-provider relationship. It focuses on, first of all, the patient treatment need, and also assisting both the patient and the practitioner to jointly arrive at a decision. Decision takes into consideration the risk, benefits, and alternatives to the proposed intervention. And it's also very important for the patient to understand how gene therapy works and why this close follow-up would be very much important to the patient after gene therapy. And recently it has been published by Valentino, a 5-step share approach by which this shared decision-making can be achieved. First, to seek the patient's participation, then to help the patient explore and compare the different treatment options, to assess the patient values and preferences, and finally to reach a decision and evaluate the patient decision. Next slide, please. And this slide only want to show you that with gene therapy there are different new tests carried out either in our laboratory or in a central laboratory we are not used to do. And this has to do something with the specific criteria which are followed by gene therapy. And this, for example, is a slide about different tests carried out to exclude pre-existing anti-AAV antibodies. In fact, I think this has not to be discussed in detail with the patient, only to show that these regular blood measurements are necessary to do some different tests which were not done previously in patients before the gene therapy area. Next slide, please. This would be very important also to discuss with the patient before gene therapy. We know from all the trials that an early transient hepatotoxicity can occur, and this is the main adverse event of AAV-based gene therapy of hemophilia. And on the right slide, you can see a very good example how this starts. This is from a trial published in 2006. This is one of the first gene therapy trial of hemophilia B. And in this trial, there was a very good factor IX expression, even with week 2 up to higher than 10%. But then at week 4, there was an ALT increase to markedly elevated levels and also an AST increase, which led to a reduction and also a completely loss of factor IX activity. And at week 12, the factor IX activity was as high or as low as before treatment. So in most cases, we see this ALT elevation in the first weeks after treatment at year 1. It is asymptomatic, so the patient do not have any problems or symptoms, and it is transient. However, the problem with this ALT elevation is that it may lead to reduced factor expression. Probably it's dose dependent. It occurs more often after gene therapy in patients with hemophilia A than hemophilia B. And we know it's treatable with immunosuppressive agents. Next slide, please. So in most cases, prednisolone is used in different dosages, but from trial to trial, some other immunosuppressive agents are used, for example, tacrolimus or some other agents. Next slide, please. And this slide points out that the monitoring post-treatment depends on several individual circumstances. For example, the immunosuppressive intervention, so immunosuppressive agents can be administered prophylactically with the aim to prevent this ALT elevation, or on a reactive basis after this ALT elevation took place. We do not know exactly if steroids or immune modulating medications are really effective at maintaining transgene expression. So there are some different results from different trials, but in any case, it would be also very important to monitor for side effects of these immune modulating medications. Then finally, it would be very important to have a close follow-up for long term to rule out any safety risk on the long term. And finally, it's more a practical issue because of the close follow-up after treatment. Some logistic help should be supported to make it possible that this blood draw and blood measurement can be done at different laboratories, and the local laboratory as well as some central laboratories if needed. So the next question, which of the following will need to be monitored on a regular 3 to 4 months basis indefinitely following vector infusion? AFP, liver function tests, factor VIII to factor IX levels, or AV antibodies. Please take your choice. And finally, and this is not really unique to gene therapy, we know also that some discrepancy in lab methods have been described before the gene therapy area, but with gene therapy we know that there would be some discrepancies in gene therapy of hemophilia A and hemophilia B. In most cases, coagulation laboratories measure the one-stage coagulation assays, and most clinicians are very used to interpret these results. In some cases, laboratories are also have also the possibility to measure the factor levels by chromogenic assays. So the chromogenic assay is a two-phase assay, and this is not PTT based. And we know from gene therapy trials in hemophilia A and hemophilia B that the one-stage assay showed higher results than the chromogenic assay. So in hemophilia B, the results are 1.6-fold higher, and in hemophilia B, the results are 2.4-fold higher. There are some models to explain this discrepancy in vivo models, and up to now, honestly, we do not know which is the true factor level we measure with gene therapy, but most probably the chromogenic assay is more related to the clinical phenotype in gene therapy. Next slide, please. And this is a slide demonstrating how this close follow-up will take place after license of a product. So before gene therapy, it would be important to have a baseline assessment of liver health, including liver function studies, AFP, viral hepatitis, exclusion of non-alcoholic fatty liver disease, or some other underlying liver comorbidities. This can be assessed by baseline fibrosis parameters, and then up to month 3 post-doses. And this, of course, depends on the possible use of steroids. The liver function parameters and factor assays should be repeated on a twice-weekly basis. At months 4 till 6 post-doses, this can be done monthly, and at months 6 till year 2 or 3, or even later on, this should be done on a 3 till 4 months basis, however, dependent on the expression and the durability profile. And finally, on a yearly basis, post-vector doses, the liver health and HCC risk should be evaluated regularly. Next slide, please.
Well, thank you, Wolfgang. So we're going to continue and talk about the longer-term evaluation of safety and efficacy beyond the clinical trial points, and really thinking about what does success look like. So if we think about efficacy parameters, there's both physiologic and clinical parameters, as well as mental health issues. So the physiological and clinical evaluation of efficacy are the ones we're familiar with from the clinical trials. The frequency of bleeding events after gene therapy treatment, what factor activity level has been achieved, what's the duration of expression, and then also some patient-reported outcomes related to any changes in pain related to their underlying joint disease. And then there have been included in the assessments some evaluation of overall emotional functioning that are also key aspects of quality of life measures. From a safety perspective, there are short-term adverse events we're looking for, long-term adverse events, and then, of course, as with anything, we want to evaluate mortality over the long term. For the short-term adverse events, you've heard about the transient hepatotoxicity that can be monitored. This is usually over within the first 6 months, maybe within the first year. Pretty unusual to see any continued abnormalities beyond the first year after treatment. We are evaluating for inhibitor development, but this has not been observed in any of the trials to date. Granted, these are all well-experienced patients who've proven to be tolerant to things like recombinant factor VIII. We don't know about what happens to patients who have a history of inhibitors, or patients who have active inhibitors, as they have not been included in the clinical trials to date, but that data will evolve over the coming months and years. The immune response to the gene therapy is important. At least with the current strategy, we do believe that the immune response after having received AAV will preclude a retreatment, but there are some interesting strategies that have been proposed to try to even overcome that hurdle. So maybe in future years, there might be an option for retreatment, at least within clinical trial experiments, perhaps for people who maybe did not get a good outcome from their initial gene therapy treatment. Thrombosis risk, we think, is probably primarily related to patients who maybe achieve supraphysiologic expression of factor 8 and factor 9. That has been seen transiently in some trials, but this risk is likely quite unusual. With respect to long-term adverse effects, of course, we want to evaluate for any development of other disorders related to gene therapy. Keep in mind that the recombinant AAV vectors are predominantly non-integrating DNA elements. They remain episomal as a sort of circular DNA outside of the genome, but at a very low rate. Biopsy specimens data has shown us that maybe it's at a rate of around 0.02 to 0.03% rate of integration. However, given the fact that we're providing trillions of viral particles to the liver cells, this still accounts for maybe tens of millions of potential integration events. There has not been any clear pathology identified related to this, both in long-term studies in dog studies or in the human trials to date, but this will remain a matter of long-term evaluation. And then we also are interested in the duration of the vector neutralizing response, which goes back to the immune response to the gene therapy. So this is one way to evaluate the pathway to preparedness for delivering gene therapy for hemophilia through the hemophilia treatment centers. This CME program is part of the education phase, and this is really what all of us should be concentrating on to make sure that we're well acquainted with the clinical trial data, which is going to accumulate from the phase 3 trials. That's where we're really going to get the safety and efficacy data, so we can have those shared decision-making conversations with our patients and with our treatment teams. We still have to wait for regulatory approval, but really regulatory approval is just step one in making this accessible to patients. Then we really need a viable pathway for access to these drugs. Depending on your health system, this might require prior authorizations, and then there are unique aspects in different health systems related to what drug acquisition will look like and what reimbursement will look like for those drugs. There's much work to be done for site preparedness, and what I mean by this is how do we prepare our hemophilia treatment centers to deliver this new platform of therapy, which is quite different from anything we have brought to the clinics previously, where we're primarily dealing with products that are prescribed and then administered in the home. So there are a chance here to evaluate what hurdles remain that we have to overcome at our sites to be prepared for delivering this unique platform of therapy in the infusion centers at our HTCs. And then ultimately, of course, we want to make sure that we are striving for excellence and in delivery and excellence in outcomes, which will come from having good standard protocols for delivering this type of therapy. So when we think about delivering access to gene therapy, drug access and reimbursement, as I mentioned, is likely going to require some innovative payment approaches. It's almost certainly these are going to be the most expensive therapies that have been brought to hemophilia to date. But because it's a one-time treatment, hopefully there will be some reduction in overall costs over time. In comparative effectiveness modeling, that seems to be the case for gene therapy based on the outcome measures we've observed. However, it's also likely that the payments are going to be linked to some specific outcome measures. It could be linked to the persistence of factor activity in that individual patient. Evidence that they have continued bleed control, can remain off prophylaxis, and are not needing much additional treatments for breakthrough bleeding events. And then, of course, reduce or eliminated need for factor replacement on an ongoing basis. What about the clinical delivery? This is where our focus really is around site preparedness. So there is work that needs to be done at your institution to be prepared for the product handling and administration of these viral vectors. That has involved in many places going through infection control committees to review the product. There's education related to nurse handling of the product up to the point of delivery to the patient, and then the infusion, the acute monitoring for that, and then patient and staff precautions, which will be determined by those infection control committees. There's also aspects of pharmacy preparedness. This will be there'll be a unique process for receiving these products, for handling it within the pharmacy. There will be unique storage requirements. On the day of preparation, there will have to be planning ahead of time for the day of infusion, because you have to account for the thaw time for the vials to be reconstituted and ready for delivery to the patient. There will need to be some form of containment during the reconstitution phase. And the experience at most centers, even if you've had experience with delivering gene therapy in the context of a gene therapy trial, almost certainly you were using your research pharmacy. And if your place is similar to ours, the clinical pharmacy is not the same as the research pharmacy. Completely different pharmacists, completely different locations, and they don't necessarily have the same facilities that may exist in the research pharmacy. So there's some preparedness there to make sure that when you're shifting to your clinical pharmacy, that they have all the pieces in place and preparedness to be able to deliver this therapy. You need to be thinking about where you will administer this. Some centers are standalone clinics outside of their health systems, but they might not be set up to actually do an infusion in that clinic setting. These are, at least for the time being, going to be adult infusions. And if your hemophilia treatment center is seated within, for instance, a children's hospital, you'll have to evaluate whether you will be able to do these administrations in your clinical setting. How are you going to observe the patient after administration? There's the 1 to 3 hours for the infusion, and then there's going to be some period of observation afterwards, just to make sure that there are no infusion-related adverse events. And so you have to think about where that's going to occur. Are they going to remain in the infusion center, or are they going to remain locally in some fashion so that you can respond to the patient if they develop symptoms? You can be thinking now about how you're going to go through subject selection at your site. What's follow-up going to look like? Dr. Miesbach laid out for you what the follow-up procedures are likely to look at and the frequency. This is a much more intense follow-up than we're used to in patients that we follow after treatments. And so what kind of systems and personnel are going to be needed to execute on that follow-up? And as with anything, as we get more familiar with this, as we develop our practice in these areas, all of this ultimately is going to lead to improved outcomes for patients over the long term. Let's go through some of the logistical needs, starting with pre-infusion. So some biological issues here. This is gene therapy with a viral vector. This is considered a genetically modified organism, and there are federal regulations regarding product handling. Most institutions have a biosafety committee which must approve the use of such materials on your campus, and you should check on this in your very specific situation. The staff, the pharmacy, the nurses, all must be trained in handling these products, and this may require some form of an online training course. Many of us had to do these as part of the clinical trials. They're very helpful, and you can incorporate that into your preparedness and workflow as specific products are approved for this use. So here's the next question. Which of the following will not be needed infrastructure for an hemophilia treatment center administering gene therapy? A pharmacy with a -80 freezer, pharmacists trained to handle this product, physicians available during infusion, case of reaction, a dedicated infusion room with a crash cart in case of emergency, or will all of these items be needed? You can go ahead and make your choice. So what about peri-infusion? You will need a pharmacy with a minus 80-degree freezer. That you need a pharmacist trained who's willing, able to handle the product. You'll need trained, skilled nurses. You'll need physicians available during the infusion in case of a reaction. These reactions are the typical biologic reactions that most of us have some experience with using biologics in our clinical practice, and usually are safely managed in the infusion setting. You need a safe area to conduct the infusion. Most likely this is going to be an infusion room at your center or your local hospital. And of course you will need appropriate resources in that setting. There should at least be some mechanism if the patient did have some sort of an allergic manifestation and need more intensive care, that they could be moved to an emergency room if that was needed. What about post-infusion? Well, you need your clinical staff to be knowledgeable about the post-infusion needs. What laboratory testing is going to be needed? Who's going to be reviewing these as they come in? You saw in the early weeks after infusion that these may be coming in at twice weekly intervals. Where are the samples going to be drawn? How does that compare to the baseline for that patient in that lab? Who's going to be reviewing those and bringing those attention for adjudication? And then if there's clinical decision making that needs to occur based on those levels, both the expression of the factor 8 or factor 9 and the liver enzymes, who's going to be making the decisions about the management for immunomodulation, and how about monitoring for the reaction of those transaminases and the factor level in response to that immunosuppression. There's some training required for the phlebotomists and nurses who are going to procure blood and body fluids. In clinical trials, many blood and body fluids are collected and processed to monitor for vector shedding in various body fluids. This is mostly to inform the community about how long it takes for the viral particles to clear. We don't believe this is going to be part of the routine management for patients post-infusion. However, there is one that I think should be important to remind people of, and this is a seminal fluid evaluation. We do recommend, in the context of clinical trials post-gene therapy, that patients use barrier methods for all sexual activity until they have shown evidence that they've cleared in the seminal fluid. And it's possible that to relieve patients of that precaution, that they may have to submit a seminal sample for evaluation to show that they are clear, or at least know that there's a concerted amount of time that must be passed before that precaution is relieved. So it's unclear what that will look like in the commercial setting. And then you need a clinical laboratory that can process the samples safely and properly. So really, this is about education and institutional training. We need in-depth gene therapy education amongst our staff. All of our staff should be able to distinguish between the different types of gene therapy in clinical trials, understand the process of AAV gene transfer, specifically as applied to hemophilia, and then also recognize the potential impact of pre-existing immunity and how that's going to affect patient eligibility. There's going to be product-specific training post-launch. So we're going to be talking. What you should be thinking about is, what does the actual label indicate, and what are the short and long-term safety and efficacy data from the clinical trial program linked to that specific product. And then I think it's good practice to be thinking about drafting standard operating procedures and workflows for delivering this new platform of therapy. These are probably going to be individualized to your clinic. Some guidance will be provided by the manufacturer. There may be some sort of templates or related publications that identify sort of checklist type approaches, so that you're best prepared to be delivering this at your center. And almost certainly there's going to be best practice sharing by sites who are already familiar with delivering gene therapy. We'll be talking about that in a few minutes, about where the experience has lied in the different US and EU settings. And those sites with experience are going to be sharing their best practices with other sites. There could be specific aspects of the process for receiving and delivering these products. How do you order this? How do you receive it? What's your day of infusion plan? What's the preparation of the product prior to administration? And these can all be laid out ahead of time so that you can deliver this therapy with excellence and achieve the best outcomes for your patients. So I'm going to turn it back to Wolfgang, who's going to walk us through an introduction to some of the systems for delivering gene therapy through the hemophilia treatment centers.
Yes, so I would like to continue with this patient journey. The patient has to do, including all the discussion before treatment, the treatment day, and also the post-treatment follow-up, laboratory measurements. And throughout this period, I think a patient support is needed, not only focused on the medical aspects, in some cases also on psychological effects. It also would be very much important to include all the other members of the multidisciplinary team of the hemophilia centers, like the nurse and the physiotherapist. It is very important that all members have the possibility to speak to the patient about gene therapy and also to help and support the patient to make a gene therapy a success. I would like to continue with these 4 universal principles for the introduction of gene therapy to people with hemophilia. And this has been proposed by a group of hemophilia experts from EU and US, including a hemophilia nurse, physiotherapists, and persons with hemophilia. They met last year to discuss different strategies for safety introduction of gene therapy into clinical practice, and also to identify its potential long-term effects on hemophilia care models in Europe and in US. And they proposed these 4 following principles. The person with hemophilia should be at the center of decision making. That means that he will be followed throughout the gene therapy by his personal hemophilia expert. All persons with hemophilia should have an equal opportunity to access gene therapy independent from their local center or also from their region or country they live. The safe introduction of commercial gene therapy with lifelong follow-up is paramount to ensure the long-term success. And finally, the integrated comprehensive care model currently employed for the treatment of hemophilia improves outcome, and it's best placed to support the introduction and long-term follow-up of gene therapy. Following on this, this group of experts identified a range of topics that need to be discussed and resolved locally in order to implement these principles. And this is in mind that we still have several challenges to implement these principles. For example, the patient information, patient selection, education, who would be responsible for this? The preparation and administration of gene therapy probably has to be done by the dosing center. Should this also be the hemophilia center? The determination of coagulation and immunological parameters, this has to be done very close to the patient's home because it's a need for do this very regularly. Change of treatment regimens, it means when should the regular prophylactic treatment with factor concentrates should tapered off. Also to detect as early as possible and to start the immunosuppression, but also it's very important the question, when can I stop immunosuppression without increasing the danger of a reduction of factor expression. Finally, follow up short-term and long-term, and who is in charge to communicate these different, very important aspects to ensure the efficacy and safety of gene therapy with all the participants. Next slide, please. So there would be some possible responsibilities, and it was last year that EHA together with EHC, so Flora Pervanti together with Detla Noon proposed a hub and spoke model, and they proposed that the hub would be the dosing center, and here are some possible responsibilities a dosing center could do. So for example, storage, preparation and administration of gene therapy, carrying out all the monitoring and diagnostic tests, of course diagnosis and management of adverse events together with hepatologists and maybe also immunologists, carry out the liver function test, imaging of the liver, start and stop immunosuppression and long-term follow-up, which probably would be best to do in long-term follow-up registers carried out by the WFH, also data consistent review, and for the local center, which has the most important role to follow the patient closely after treatment, it would be important, first of all, to select the patient, to enroll a patient and to perform the patient consent, do some counseling about treatment options, not only gene therapy, because we know that other treatment options are very good, established and safe in hemophilia. The regular blood collection for the hub center to prescribe immunosuppression in collaboration with the hub center, and finally to perform the regular follow-up and long-term follow-up and the ongoing support of bleeding episodes. Next slide, please. And this has been proposed by this group that there may be not only one center caring for the patient, but there may be different centers who may share their responsibility for a successful gene therapy. And this, of course, would be the dosing center. The dosing center can be the follow-up center, can be the supervisory and coordination center, but it can also be that other centers would do this role. So in total, we may have 3 centers with different interfaces, and of course, it's very important to ensure that a very good cooperation and communication would be in this place to make gene therapy as efficacious and safe as it already has been done in clinical trials. And this interaction between the dosing and home center may include the regular laboratory measurements before gene therapy, mainly to see if all the inclusion and exclusion criteria would fit and pre-existing anti-AAV antibodies would be excluded, to manage a possible travel between the dosing center and the management center, and finally to organize and coordinate the regular laboratory measurements after gene therapy. And these are only a couple of questions which have to be decided and agreed, cooperated between the different centers taking place in the same gene therapy of one patient. For example, when to stop regular factor replacement, how to detect as early as possible ALT elevation, and finally, when to start and stop immunosuppressive treatment if necessary. And finally, I think it's only 1 or 2 weeks ago, this paper has been published about potential division of responsibilities among one or several hemophilia treatment centers, and in this paper a more detailed overview about the different responsibilities is given regarding the hub and spoke model. This is a joint publication of EHAT and AHC, and it proposes how AAV-based gene therapy could be delivered through the existing hemophilia centers, but there would be a need for re-evaluation of infrastructure and comprehensive care.
Thank you, Wolfgang. And so now we're going to give you just a few minutes, some perspective on the US and EU HTC organization as it may be applied for gene therapy. So this is a distribution map of patients with hemophilia showing where some of the densities of patients with hemophilia exist. And we can overlay that with our regional structure, which is the federally designated regions. And you can see how they're divided up across the US. And then this shows approximately 36 sites that we're aware of that have gene therapy experience related to the clinical trials. And you can see actually these overlap quite nicely with both the population density in the US as well as there's representation across each of the 8 regions in the US. But we do note that of these 36 sites, best we can tell, about 9 sites have never actually dosed a patient in a phase 3 trial. And that's because as they were trying to get up and running, they encountered some institutional infrastructure barriers that had precluded them being able and ready to do that. And so this is going to be an issue even as we shift to the commercial phase. As we mentioned in the clinical trials, we're working with investigational pharmacies, clinical research centers, and there are dedicated research nurses and coordinators. But we think in this first phase of rollout of gene therapy is probably going to be centered in the specialized and experienced HTCs who've already had some experience with this in the gene therapy trials. But there is going to be this shift from the investigational pharmacies to the clinical pharmacies. Now we're going to be engaging our clinical nurses and our clinical coordinators. There's needs related to patient education. We mentioned infection control committee reviews, and then some evolution of our care models and our standard operating procedures. Once that initial phase of delivery rolls out, I believe there will be a second phase of expanded HTC engagement, particularly taking advantage of sharing of best practices amongst the HTCs. The question is as we start having this model of coordinating centers, dosing centers, follow-up centers, what kind of shared reimbursement models are likely going to need to involve to cover the care of the patient if they do move between centers? Some of the unresolved challenges in the US, the reimbursement and funds flow model, what does this look like with a hub and spoke delivery structure and a private pay model? These are open questions. There's been limited experience with patients moving fluidly for services between HTCs. And so how can we adapt our protocols to accommodate that? As I mentioned, institutional approvals and local infrastructure needs are important. These are things we can be working on now. About a quarter of approved US clinical trial sites were never able to get to the place of dosing a patient in a clinical trial. There are personnel and staffing issues. We're going to be leaving the high levels of supports of our clinical trial infrastructure and shifting to an already heavily burdened clinical care infrastructure. And so we're going to have to make some accommodations to embrace some of the close follow-up that's needed for the commercial delivery of gene therapy. And then we mentioned development of standing operating procedures and sharing of best practices. We think the US HTCs have a collaborative and integrated national infrastructure of 8 regional hemophilia networks that can accommodate this. There are institutional infrastructure barriers that are still a challenge, and this hub and spoke model really hasn't been had good examples yet within our system. HTC preparedness right now should focus on educational priorities, and then reimbursement and funds flow may be the most critical hurdle going forward. But I wonder, Wolfgang, if you can share some perspective on what some issues are in the EU.
Thank you, Steve. I will do this very briefly. In Europe, we have about more than 400 hemophilia centers, but they show a great variability. So some centers have a huge number of patients and some only very few patients. Also, the laboratory possibilities and the on-call care differs. In addition to that, there are some countries with a huge number of hemophilia centers in Europe, and there are some countries with only 1 or 2 great hemophilia centers. So up to now, there is no generally accepted definition, and there are several names for different hemophilia centers with different expertise. Now there is a very good and very well established certification process by EHAT, and with this process several criteria have been proposed, and now more than 117 centers fulfill these criteria and are comprehensive care centers. In addition to that, 42 centers also have been certified and now are European hemophilia treatment centers. So these both centers differ in terms of number of patients and possibilities to treat the patients. Next slide.
There we go.
So to summarize, in Europe, we see a country-specific variability of hemophilia care in terms of standardized treatment. There is a progress made by EHAT to certificate hemophilia centers, and to our opinion, the access to gene therapy should not be limited by location, founding, or lack of knowledge. So we should create the possibilities for every patient who would like to be treated with therapy and also fulfills the inclusion criteria to get this treatment. Most probably, the best idea would be that gene therapy would be managed using a hub and spoke model. However, solutions for founding need to be found locally.
Yeah, so I think we'll just wrap up here because we won't want to be able to take a few questions, but there's going to be evolving knowledge from gene therapy, even in the commercial phase. And we recognize with such limited numbers of patients and looking for adverse events in already a very rare disease that we're going to need some strategy to collect this data. So there's going to be both country level data that's going to be collected even beyond the clinical trials, and the World Federation of Hemophilia, as Wolfgang mentioned early on, has just launched a gene therapy registry, and this will be able to incorporate data not only from the clinical trials but also from our centers as we roll out commercial gene therapy, and that will inform the community over the long term. There are a few post-test questions that we want to just get through quickly. So these are the same ones you saw before, so you can just quickly re-answer these questions based on what you learned today. This is first question here. If we can, we'll go to the next question. It's related to post-infusion adverse events. I'm going to pick the least likely one. This is the one related to post-infusion monitoring. And this is the one related to which of the following will not be needed, but you can pick the best answer for this question. And then we want to make sure that you're able to claim credit. So I did see some important questions that I wanted to address. Someone asked about, there was a single case in the phase 3 trial for Unicure for Hemophilia B, where a patient did not receive the full dose due to an acute infusion reaction. That's correct. And that was I guess I would say a typical allergic reaction, but the patient had some underlying risk factors that the clinician was concerned about, and they weren't sure how to proceed, and so they just elected not to finish the infusion. To my knowledge, across all the clinical trials, these infusion reactions have been seen from time to time. They are generally manageable and sometimes can be improved just simply by slowing or briefly interrupting the infusion and then restarting at a lower rate, maybe with some supportive medications. There was a question about a recent hepatocellular carcinoma case in the Unicure trial, again, in the phase 3 trial. This occurred within 1 year of treatment. However, this patient had long history of known risk factors of hepatocellular carcinoma, including hepatitis B and hepatitis C, and evidence of non-alcoholic fatty liver disease. The genomic analysis was very detailed for this patient, and we just presented ISTH that it's unlikely that this was related to the gene therapy intervention. However, it did highlight that there are multiple mechanisms that can lead to the development of hepatocellular carcinoma, and non-alcoholic fatty liver disease may be another one of the criteria related to liver health that we need to be paying attention to. Is there a discussion whether the companies will be designated which HTCs meet criteria for administration of their gene therapy? Yes, that was done with some therapies. Someone mentioned Luxturna, which was an intraocular delivery. I believe the rationale for that selection of sites was because it required very specific surgical expertise in order to deliver this therapy. The gene therapy as it's being used in hemophilia, I've not seen any barriers with which any center that is accomplished at delivering biologic could not deliver gene therapy. And so I don't think there's a need for a designation like that by the company as to who's qualified to deliver a gene therapy. So what is more likely to happen is what you saw laid out by Wolfgang related to the responsibilities of a dosing center. That's what's going to be the criteria. And I believe that could be a self-declaration based on evaluation of yourself and a checklist phenomenon of whether you can rise to the standard to do gene therapy at your center. Several people had asked questions about, could gene therapy be delivered at home? I don't think so in the early phases. I think it's important that this be prepared on site and delivered in the observation of a clinic infusion center. So almost certainly that's what it's going to look like for the time being. What are your thoughts about vector shedding, Wolfgang? Someone's asked about that. Is this going to be an issue for monitoring, or do we perceive any risks for the extended family for a patient during the vector shedding phase?
Yes, it's a good question. So in fact, I don't think so. So it was a big issue when starting with gene therapy trials. We did a lot of laboratory investigations on different body fluids, and to my knowledge, the vector shedding varied from study to study, and but I think there is no hint in the literature or evidence that the delivery of this gene particles, so it's not the complete gene, it's only fragments of the gene particles in some body fluids, would lead to a serious health problem. On the other side, I think, and this is what we always recommend and advise to our patient, that they should use barriers for sexuality. So because we do not know, I think it would be very important to avoid the vector shedding in this case. But in any other cases, I do not think that this would be an health problem at all. I think we are just a little bit over time, but maybe we can prolong a little bit longer, Steve, if you don't mind, to see if we could ask some more questions. There was a very interesting question. I see how many gene therapy preparations can on average university hospital or some other hospitals pharmacy handle per day. And then also probably it would be dependent on founding if gene therapy could be done only on the ward or also at an outpatient department.
Sure.
I
Yeah.
think you
Yeah. Our,
already
our our
mentioned that.
experience is the outpatient setting was perfect for this in the gene therapy trials. I think we'll do the same approach in the commercial setting. We did have some coordination with our adult colleagues to use the infusion center, but we trained them in advance. There's no way we could do more than one of these in a day. The time devoted to the pharmacy to thaw the material, reconstitute it, and then you deliver this hopefully late morning after you get through that, and then it takes up to 1 to 3 hours depending on the protocol for the infusion, and then you have a period of post-infusion monitoring. So it's a whole day for that patient and for the treatment team, and then probably for the first, I would say 24 hours, you want the patient to be in some proximity to the center. They might not have to be in the hospital campus, but we had them stay, maybe locally, so that we could check in with them if there are any late infusion reactions before we let them go. So I don't think the hospital admission is a requirement, but there were some examples in the trials where someone had an infusion reaction and they deemed it better to observe them in the hospital setting. But in our experience, that was very unusual.
Thank you. I have another question to you. Gene therapy offers the promise of phenotypic cure of hemophilia. And these people or these persons with hemophilia who would benefit most from this are very young children or adolescents. And we do not know how they react and if this would be an option in the future. Another group of patients who also would benefit most would be patients in the developing countries, where the management of hemophilia is not as advanced as in the Western countries.
Yeah.
And do you think in the future both of these patient groups could benefit from gene therapy?
Yeah, I certainly hope so. I don't believe gene therapy as it's being applied now in adults is going to alter the phenotype of having a bleeding disorder, because 18 years plus of accumulation of pathology, we might further change the trajectory of the development of joint disease and push it down the road several decades, but I don't think it will eliminate that risk over the long term. It's definitely going to have an impact on the costs of therapy for prophylaxis, etc. So if we want to do phenotypic transformation, that has to occur in the young child before the onset of recurrent joint bleeding. And I don't believe there's any prophylactic product that has completely abrogated all risk for joint bleeding. But gene therapy could do that. It's probably not going to be this particular platform, this recombinant AAV liver-directed platform. Almost certainly we're going to have to embrace either some sort of non-viral delivery that could be repeated in cycles over the life of the patient, or a gene editing type approach or a cellular therapy, which are being explored in trials now in other settings, but maybe could be adapted for hemophilia. So I'm looking forward to that. In the developing world, though, there's still a chance here that you could, by transforming patients' clinical utilization of factor at age 18 and above, that would allow you to redirect resources to your younger patients. So most of the factor products could now be used in the younger children, preserving their joints until you got them to age 18 or at least late adolescence, where gene therapy might be able to be applied. So I'm hopeful that this will be a real inflection point for the developing world as well. Well, I think we have to wrap up. I don't know if we need to flash up the QR code one more time. I really appreciate everyone's involvement today. Thank you for the great questions. I hope you found this informative. There will be an enduring format for this as well that you can share with your colleagues. And thank you to France Foundation for helping coordinate all this and for our sponsors who made this possible. Have a great rest of your day.